This presentation is going to cover pacemakers. First, we're going to discuss the components of a pacemaker. Pacemakers have a power source, they have some voltage wave amplifiers, transmitters and receivers to speak to the pacemaker and to adjust it. It has an internal clock, and it also has some sensors. First, let's talk about the electrical wires. The electrical wires inside of a pacemaker are basically used to transmit electrical data from the heart to the pacemaker and vice versa. These pacemaker wires could either be unipolar or they could be bipolar. If you're not sure what each one of those means, there is a presentation in my 12-lead class that discusses the difference between unipolar and bipolar leads. Here's a couple pictures of the components of the pacemaker. This is an older one that I've had for a long time. You basically have an area right here, which is the battery. It's a very long-lasting battery. They usually last somewhere between 5 and 7 years. On another side over here, you have all your components. You have a microprocessor, pulse output circuits, amplifiers, all kinds of stuff over here to help run the pacemaker. And of course, usually somewhere else in the pacemaker, you have a place to plug in your pacemaker wire into the pacemaker itself. As you can see here, this would be your housing for the pacemaker that would have the battery and all of the electronics, the transmitters, the receivers, the circuitry necessary to run the pacemaker. And then the pacemaker wire would fit into this spot right here. What I like about this picture is that I want you to take a look at the tip of this pacing lead right here. It looks like it's a wire that has some barbs in it. The function of those barbs is to stick into the right ventricle wall, into that endocardium and part of the myocardium there, to really hang on during the forceful rigors of contraction. So when a pacemaker is placed, it will either be a single chamber pacemaker or a dual chamber pacemaker. If it's a single chamber pacemaker, that means it either runs it into the right atrium or the right ventricle. It's nice to note right now that a pacemaker is not run into the left atrium or the left ventricle. Usually it is run into the right atrium or the right ventricle. So in this case, as you can see here, as a single chamber pacemaker, this one's going down here into the right atrium. If it's a dual chamber, which means it paces the atrium and the ventricle, they'll run one wire with 2 electrodes or 2 wires, one that stops up here in the right atrium and then one that stops down here in the right ventricle. When programming a pacemaker, we need to classify a couple different types of pacemakers. One type of pacing that a pacemaker will perform is synchronous pacemaking. If a pacemaker is synchronous, that means it works with the heart. That basically means that a synchronous pacemaker will take its cues from the heart. It is a demand pacemaker, and it will pace only when the heart rate falls below a preset rate or when it's programmed to do so. An asynchronous pacemaker is something that's called a fixed pacemaker, and what that basically means is that it is going to pace regardless of cardiac activity. For somebody to have an asynchronous pacemaker, you have to consider that this person is going to be extremely sick. This is going to be a very sick heart. A little bit more rare because it can cause problems if you have a fixed pacemaker. So more often than not, it is the synchronous pacemaker that is placed in somebody that works with the heart. I would like to talk about the Inter-Society Commission for Heart Disease 5-letter code that is used to identify the function of a pacemaker. In the past, this information was given to the patient, so if the patient had to be taken back to the hospital or go into the emergency department for some reason, they would have the type of pacemaker, who placed it, the 5-letter code giving the function of the pacemaker, and any other information necessary. It's pretty simple to get that information, but it always helps to have that information with the patient. So we're going to talk about this 5-letter code. The first letter code right here, and we'll talk about the letters here in a second. The first letter is the chamber paced. The second letter is going to be the chamber sensed. And I'll discuss what each one of these means here in a second. The third letter is going to be the activity of the pacer. And what that means is it's the response of the pacemaker. What is it designed to do? The fourth and fifth letters, in my class, I'm not going to test you on the fourth and fifth letters. But just to let you know, the fourth letter is rate modulation and the fifth letter is anti-tachyarrhythmia functions. We will talk about those, but I really want to concentrate right now on the first three letters. The first letter is the chamber that is paced. This is simple. The A stands for atrium. The V stands for ventricle. D is for dual, which means it paces the atrium and the ventricle. O is set to none, which means it would not pace the atrium or the ventricle. Different doctors have different reasons to set it up for it to not pace. Maybe it's not a pacemaker, maybe it is a cardioverter defibrillator. But the first letter stands for which chamber is paced. The second letter is the chamber that is sensed. A stands once again for atrium. V stands for ventricle. D is for dual. O is for none. The third letter is a little bit more complicated. This is the response of the pacemaker, or as I said it earlier, the activity of the pacemaker. I'm going to describe these as we go through them, but I want to list them out first. T stands for triggered. I stands for inhibited. D stands for dual, which means it's both triggered and inhibited, and O is for none. What do each one of these mean? Triggered response, or the triggered activity of the pacemaker, means the pacemaker will depolarize after sensing a certain event, or the pacemaker is active or activated after a certain event in the heart. For example, and I'll give you an example, a P wave may trigger the event. So if the pacemaker senses a P wave, the pacemaker will be activated to do something specific. An inhibited event means that the pacemaker will not do something when it senses a certain event. So basically the pacemaker is deactivated after a certain event in the heart. For example, a QRS complex, which means if the pacemaker is meant to pace the right ventricle, it will be inhibited if it senses the ventricle depolarizing by itself. Because you don't want to have the pacemaker trying to depolarize the right ventricle if the right ventricle is already doing its job. That would be an example of an inhibited event. In a dual event, what that means is that the pacemaker is triggered by something but then inhibited by something else. So it's activated by an event like a P wave, and then the pacemaker is inhibited or deactivated by another, usually a separate event. The O would be set to anything that is not a paced rhythm. It would be like if it were a defibrillator. When we use the third letter of the ICHD code for the activity of the pacemaker, many times it has to use something called a ventricular escape interval. This ventricular escape interval will sense an atrial complex and then start a timer. And I'm using this as an example. If the event does not occur before the time runs out, which would be that ventricular escape interval, then the pacemaker will perform its job. So in this case, let's pretend that this pacemaker, the third letter, is set for D, or dual, which means it is triggered by a P wave but inhibited by a QRS complex. What they will do is they will set a ventricular escape interval that when the pacemaker senses a P wave, it will start a timer in milliseconds. And let's say for fun, the timer is set for 240 milliseconds, which is equivalent to 0.24 second. So the pacemaker is set to have a ventricular escape interval of 240 milliseconds. It senses a P wave, which activates this timer. If there is a QRS before this point, it will inhibit the pacemaker and not let it fire. What happens when you have another P wave? Well, it restarts the timer for 240 milliseconds. During this time, we'll pretend that this right here was 240 milliseconds, or 20.24 seconds. What happens is when this timer runs out, it will then perform its job. In this case, its job was to depolarize the ventricle. That is an example of a ventricular escape interval. We're going to talk about a couple more because this isn't just the only type of ventricular escape interval. The fourth letter of the code, of this ICHD code, is something about a rate modulation. Like I said in my class, I will not test you on these unless it's extra credit. So let's talk about the first one. P is the basic programmable functions. These are just some basic programming functions. M is for multi-programmable functions. C is for communicating or communications. People can communicate with pacemakers through using proprietary communication, near field communication systems. R is for rate responsiveness. Which basically means you can adjust the rate to fit the patient's needs for hemodynamic stability. So if you need to increase the rate of depolarization or decrease the rate of depolarization of the pacemaker to make sure the patient meets the minimum cardiac output. O, like all the other ones, is set to none, or it's not set. The last code is anti-tachyarrhythmia functions. P is for pacing, and not the kind of pacing that we're talking about here. Specifically, this is meant for overdrive pacing. I haven't seen overdrive pacing in a really long time, but basically what overdrive pacing is is that if somebody has a narrow complex tachycardia at 250 beats a minute, there is a hardware that can be put into the patient's right ventricle, and then the hardware can start pacing the patient at, we'll say, 280 beats a minute. In the ideal world, if the heartbeat is 250 and you start pacing it at 280, you can capture the rate of the heart, and then you would slowly turn down the rate on this external module that you would have at the bedside that would overdrive pace, and it would slow down the heart rate. It's called overdrive pacing. S is for shock, which is actually for any kind of implantable cardioverter defibrillator. So that's usually the implantable cardioverter defibrillator of a patient who goes maybe into VTAC. If you have a patient that goes into VTAC, it will shock the patient. D is set for dual, which would be weird to set it to overdrive pace and to defibrillate, but I guess some people's hearts are that bad. And of course, O is set to none. When we talk about the 5-letter code, we concentrate on the first 3 letters, which is pacing, what chamber the pacemaker will pace, sensing, what chamber the pacemaker will sense, and the activity of what the pacemaker does. If you notice this acronym right here, this is something that I use to remember the first 3 letters. This is something that I remember as a public service announcement. PSA is a common abbreviation for a public service announcement. If you use PSA, you'll know that it is the first letter is the chamber paced, the second letter is the chamber sensed, and the third letter is the activity of the pacemaker. Let's talk about some different pacemakers and what they will do. First, we're going to talk about atrial demand pacemakers, and this is something called an AAI. So AAI, what does that mean? That means that it paces the atrium. The second letter A means that it senses the atrium, and the activity is inhibitory, which means whatever goes on in a heart deactivates the pacemaker. What this requires is a functioning AV node and an intact conduction system. Some patient conditions that you may run into in this situation would be any symptoms producing something like a sinus bradycardia, or something we haven't discussed, which is a sick sinus syndrome. A sick sinus syndrome is a problem with the SA node that causes it to go into extreme tachyarrhythmias and extreme bradyarrhythmias as well. In this case, an AAI pacer would help the sick sinus syndrome when it goes into the severe bradycardic arrhythmias. Continuing about AAI pacemakers, the AAI pacemakers use something called an atrial escape interval. We just recently talked about a ventricular escape interval, but there is something also called an atrial escape interval. This doesn't sense any of the stuff that's going on in the atrium. So remember, it paces the atrium, senses the atrium in an inhibitory manner. So the wire only goes into the right atrium. In this case, what happens is you set the atrial escape interval to a certain milliseconds, to some kind of milliseconds, to make sure that the heart rate doesn't fall below a certain beat per minute. If there is a P wave, it reset and restarted the atrial escape interval. Every time the P wave occurs, it resets the atrial escape interval. What happens if the atrial escape interval expires? You will end up with a pacer spike that will cause a P wave, and then the heart will just take over with the QRS and the T wave. If the atrial escape interval expires again, it'll pace the atrium only to go ahead and make sure the heart rate stays at a certain hemodynamically stable heart rate. Another pacemaker is a VVI, and what that means is it will, and I'm going to put my P, S, and A up here, so it paces the ventricle, it senses the ventricle, and it works. The activity is inhibitory, which basically means a QRS complex will inhibit the activity of the pacemaker. This also uses a ventricular escape interval, but it's not the same ventricular escape interval that we talked about previously, and I'll explain what that is here in just a second. The patient conditions that a VVI pacemaker is usually used in are very common in patients with an atrial fibrillation. Usually the atrial fibrillation will have a very slow ventricular response. And that's a common time that you would use this pacemaker. I just said that the VVI uses another ventricular escape interval. The ventricular escape interval we talked about before, it was activated by a P wave and then deactivated by a QRS complex. That's not what we're talking about here. Now we're talking about a ventricular escape interval. Since it paces the ventricle and it only senses the ventricles, there's no way to know if the P wave is occurring or not occurring. Since it's only sensing the ventricles, it's only looking for QRS complexes. So once again, like the atrial escape interval, it will sense whenever there is a QRS complex, and it will start the millisecond timer. And if another QRS complex occurs, it will stop the timer and it will reset it. Now, here's your millisecond timer, and what happened to your timer? It expired. So what did the pacemaker do? It senses the QRS, the ventricular escape interval expired, so it paced the ventricle, giving you a pacer spike and a huge, wide, bizarre-looking QRS. What happened right here? The ventricular escape interval timer expired again, caused a pacer spike, and caused a big, wide QRS complex. The next pacemaker I want to discuss is a DVI pacemaker. So I'm going to put P, S, and A. What does a DVI pacemaker do? Well, it paces the atrium and the ventricle. It senses the ventricle in an inhibitory fashion. So this also uses the ventricular escape interval as well. DVI pacemakers can also have another function and be programmed to either be a committed or a non-committed pacemaker. In this case, the DVI pacemakers, it senses the ventricles. So it is using the ventricular escape interval. It is measuring the R to R interval in milliseconds. What happens if this ventricular escape interval expires? What does it pace? Well, it will pace the atrium and then it will pace the ventricle. In a committed pacemaker, what that means is if the ventricular escape interval expires, it will pace the atrium and the ventricle. Regardless of what the heart does. That means that once it commits to pacing the atrium and the ventricle, it's going to pace the atrium and the ventricle. Even if the heart tries to do its own QRS after it's paced by the atrium, it doesn't matter. The pacemaker, once it commits to pacing the atrium in the vehicle, it starts it and it does it. In a non-committed pacemaker, what will happen is it will pace the atrium and then wait to see if the ventricle responds. If the ventricle does not respond, then it will pace the ventricle. So in this case, what will happen is the ventricular escape interval, no atrial escape interval on this one. This is the pacemaker we were just using, the DVI. What happens is there is a ventricular escape interval that starts right here. The ventricular escape interval sensed that the ventricle depolarized, so it reset the ventricular escape interval. Once this interval expired on this DVI pacemaker, it paced the atrium and then paced the ventricle after that. Now, I don't know if this picture is a committed or non-committed example, but the point is that once this ventricular escape interval expires, as you can see here again, pace the atrium, pace the ventricle. Atrial synchronous ventricular pacemaker, or a VDD pacemaker. Let's look at it this way. Here's your P, there's your S, there's your A. So what does it do? It paces the ventricles, it senses the atria and the ventricles, and it does the activity of triggering and inhibition. Usually that means that it is triggered by a P wave and inhibited by a QRS complex. There's also the DDD pacemaker. So what does it pace? Remember, we have our P, S, A. So it paces the atrium and the ventricle. It senses the atrium and the ventricle. And the action is triggered and inhibited. This acts as a whole bunch of different types of pacemakers, an AAI, DVI, and VVI as well. This pacemaker, we're talking about the DDD pacemaker. It uses both ventricular and atrial escapes intervals. PACs, PJCs, and PVCs will also cause inhibition of the pacemaker. So as you can see here, it's using the atrial escape. I'm sure it'll also using the ventricular escape intervals. But when we got down here, what did this PVC do? It actually reset the timer. Let's talk about the different types of pacemakers. Permanent versus temporary. We're going to talk a little bit more about the temporary. There's a few temporary ones that we use on a regular basis, and they're kind of neat. But first, we're actually going to talk about the permanent pacemakers. Permanent pacemakers are placed transvenously and then anchored in the endocardium. That's the pacer wire that is actually put down into the right atrium or the right ventricle, and it's kind of burrowed into the myocardium itself. They're placed transvenously, which means they go in, as you remember from the picture before, from that subclavian artery down into the right atrium or the right ventricle. Treats chronic heart conditions, and there could be something called biventricular pacing for really, really bad heart failure, but biventricular pacing is not as rock solid as just putting it into the right ventricle. Biventricular pacing occurs where one lead, so you have a lead placed into the right atrium, a lead into the right ventricle, and then so you have one lead here, two lead here, and then you have a third lead that is placed And this lead goes through the cardiac vein, and then it is placed over the left ventricle. Not into the left ventricle, but over the left ventricle. This is a way that you would do biventricular pacing. The problem with this is that when this lead is placed over the left ventricle, yes, it will stimulate the left ventricle, but it is doing so from the outside of the ventricle, which means the lead could easily become dislodged. Very easily dislodged. Now let's talk about some temporary pacemakers. Temporary pacemakers are, first we're going to talk about a transvenous temporary pacemaker. The placement of this pacemaker usually uses fluoroscopy at the bedside. So they use a fluoroscopy process at the bedside to put this in through the vein itself. It is inserted through the subclavian or the internal jugular. Vein. And then what happens is it is anchored in the right atrium or right ventricle. The wires that are sticking out are then connected to the pulse generator. Most common, and this is the most common temporary pacemaker. And it's the most reliable. Another temporary pacemaker is something called an epicardial pacemaker. This is most common after cardiac surgery. Attachment of the wires is usually to the surface of the heart through the chest wall below the incision, like if it were a cardiac surgery, like an open heart surgery or something. Removal of the epicardial pacemakers are usually done several days later, or if there's no more needed for the patient. And those are epicardial pacemakers. The next pacemaker is the transcutaneous pacemaker. This one is very quick. It's very non-invasive. Method of pacing. It's usually used in emergency situations. For example, EMS will use this a lot. Pre-hospital medicine will use this a lot. Whenever you take a patient to the hospital, a lot of times in the emergency department, it is much quicker just to place the external pacing defibrillator pads on the outside of the patient and start pacing. They won't jump to the transvenous pacer right away. They'll start transcutaneous pacing first. If continuous pacing is needed, they will eventually put in a transcutaneous pacemaker. Transthoracic pacemakers are a very, very last resort just because of the way they're placed. Placement itself is usually done with a needle which is inserted into the right ventricle using a subxiphoid approach. Once they get it into the right ventricle, then a pacer wire is guided into the endocardium. Next, we're going to talk about complications of pacemakers. There are several complications that will occur with pacemakers once they are placed. This isn't complication placing them, this is a complication after they've been placed. Three of the ones that we're going to discuss is a pacemaker's failure to capture, failure to pace, and a failure to sense. Each one of these can cause serious problems and cause hemodynamic instability in a patient. First, a failure to capture. What happens in a failure to capture is that the appearance on the monitor will be a pacer spike without a complex. Following, which means you'll have your baseline, you'll have a pacer spike, and let's say that this is an atrial pacer, you won't get a P wave after it, and then later you'll have another pacer spike, and then there will be a P wave after it. So this would be an example of a failure to capture. What this means is the pacer did not stimulate the myocardium. Usually this kind of stuff is caused by increasing thresholds, increasing pacing thresholds, which could usually be caused by metabolic or some kind of electrolyte problems. It could also come from antiarrhythmics. So if a person is on some type of antiarrhythmic for their heart, it could also come from where the lead attaches to the myocardium. Sometimes that will develop some fibrous tissue, so fibrosis at the site. Oops. Lead malfunction could occur also, which means the leads could be broken or damaged somehow. They could come dislodged. They could lose a connection between the pulse generator and the lead, or the lead and the myocardium. Those are the biggies for that, for the lead malfunctions. For interventions, how would this be treated? Well, you basically have to find out what the problem is. If it's a metabolic problem, you treat the metabolic issue. If it's an electrolyte issue, you treat that. If it's an antiarrhythmia medication that's causing it, maybe you just need to increase the amperage or the milliamperage of the pacemaker to make sure that it can pace the heart. If it's a fibrous site, you have to kind of move the wire. You can't just leave it there, because fibrous connective tissue is non-conductive. It does not stretch, it does not contract, it doesn't do anything. Fibrous connective tissue just basically fills a hole of an area that was damaged. If it's a lead malfunction problem, if the leads are broken or dislodged, you just have to go in there and put them back together. Either way, the big deal about this is that the patient needs to be treated and transported. Now let's talk about a failure to pace. When you have a failure to pace, what you see on the monitor is you see a missing pacer spike where there's supposed to be one. So for example, if you have a pacemaker that is set to not let the heart go below 60 beats a minute, and the heart is going below 60 beats a minute, that means that the pacemaker is failing to pace. What this means is the pacer is not firing as it's programmed. This can be caused by battery issues. There could be a circuit failure within the pacemaker itself. It could be a lead malfunction. It could also be inappropriately programmed. There could also be, and this isn't much of a problem anymore, some kind of electromagnetic interference. Electromagnetic interference used to be a huge issue, and sometimes that's why when you walk into certain areas of buildings, it'll say something like microwave in use, because that would interfere with a pacemaker. Nowadays, there's much better electronic shielding, so it's not as much of an issue, but it still could be an issue. A failure to pace could lead to some problems. It could lead to a patient going into asystole. It could lead basically into any type of decrease in cardiac output. Some interventions about this. Well, first of all, you probably need to put in a temporary pacemaker. But basically what you need to do is find out what the problem is. If it's a battery issue, you replace the battery. If it's a circuit failure, you might have to replace the entire pacemaker. If it's a lead malfunction, you plug the leads back in or you replace the leads. If it's a programming issue, they can program it again from outside of the body without having to go in. If it's some kind of electromagnetic interference or anything else, they might have to figure out, how do we protect the patient from doing this? Don't go near microwaves and stay away from large magnets. That might actually be the best intervention for them. The next complication of pacemakers I want to discuss is a pacemaker's failure to sense. When a pacemaker has a failure to sense, it has two problems. It has an undersensing problem and an oversensing problem. Undersensing means that the pacer is under sensing what the heart is doing, which means it is not sensing what the heart is doing. So what that means is you'll have your normal P, Q, R, S, and T's, but the pacemaker doesn't detect P waves or T waves or S or QRSs. It's not detecting the electrical components of the heart, which is a problem because that means that the pacemaker is still going to depolarize, which can cause life-threatening problems. So you'll have a normal P, QRS, and a T wave, but the pacemaker isn't sensing any of this, so it's trying to depolarize. The pacer spikes will be all over the place. It'll try to start depolarizing the heart. This could be a life-threatening problem because then you can end up with an R on T phenomenon. If a pacer tries to spike itself right here, it could send the person into a lethal arrhythmia. This can be caused by battery failure. It can be caused by damaged wires. It could also be caused by displacement of the electrode down into the myocardium. So there's a few different problems that this could have. The best intervention is to replace the battery, replace the damaged wires, figure out what the problem is, and get this thing back on track. Oversensing means that the pacer is sensing everything that's going on. So it will detect every little electrical anything that might occur in the body sometimes. If you ever put a person on the monitor and maybe you have some baseline artifact or you have some kind of artifact going across the monitor, what can happen is the pacer will sense every single little piece of artifact, and that is bad because if the pacer is using a ventricular escape interval or an atrial escape interval, every single time that it detects an electrical something, it will reset these timers prematurely. That can cause a severe drop in the patient's cardiac output and hemodynamic stability. Usually this is caused by improper settings of the pacer. The interventions here, you just need to transport the patient. So let's interpret some rhythms. I like to do this a little bit because I like to show how I want them to be interpreted in my class, which will make a little bit more sense. So the first one we're going to look at here, just follow the normal 6-step process. Atrial. Do we have any atrial? We do not. So they're unable to obtain or none. Ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we'll say it's about 100 beats per minute. That seems like a lot. Is it really 100, 300, 150, 100? Yeah, it might be. Regularity, when it's paced like this, it should be regular. If it's being paced and it's irregular, that's a problem. P waves are absent. PR interval is none. The QRS complex, normally the QRS complex width starts at the pacemaker site if it's ventricular paced rhythm. So in this case, let's pretend it starts right here. So there's 1, 2 boxes, 1, 2, another 2 boxes, so 0.16 second. How do you interpret this? You can't interpret it with a sinus rhythm, and you can't just call it paced. Because if it's paced, it's going to be atrial paced, it's going to be ventricular paced. Is there a capture? Is there no capture? What's going on? The way to interpret this is a ventricular or ventricle paced with complete capture. Let's look at the next one. Are there P waves? There are P waves, actually. There's a little P wave here, here. There's P waves before each one of these. So we have an atrial rate of 1, 2, 3, 4, 5, 6. So we have an atrial rate of 60 beats per minute. The ventricular rate, this right here, what the arrow is pointing to is a PVC. So we have a ventricular rate of 1, 2, 3, have to count that, 4, 5, 6, 7. Regularity, in this case, because of that PVC, is going to be irregular. P waves are present and married. The PR intervals start right here at the pacer spike, and you go backwards. So there's 2 boxes, 1, 2, 3. So that's about 5 boxes, so 0.20 second. QRS complex, we start right here at the pacer spike and we go 2 boxes there, and it looks like it stops down here, so there's 3 boxes there, so that's another 0.20 second for the QRS width. This one is a little bit different. It's not just ventricular paced because we also have an atrial rate with P waves. So in this case you would say that it's a sinus rhythm with ventricular pacing with complete capture. And what else do we have? And a PVC. In this one, we have something a little bit different. It's an atrioventricular pacer, so it's a dual chamber pacer. Do we still have an atrial rate? Yes, we do. We have pacer spikes. So let's count the pacer spikes. 1, 2, 3, 4, 5, 6, 7. So we'll have an atrial rate of about 70 beats per minute. A ventricular rate of about 70 beats a minute. It should be the same. For regularity, I'm assuming it's regular. I'd have to get out my calipers. P waves. Are they present? Yes. Are they married? Yes. You can put present with the pacer. PR interval, just count from the pacer spike to the pacer spike. That looks to be about 0.16 second. QRS complexes start here, so that's about, those are really narrow for a paced rhythm, so about 0.12 second. Now in this case, the interpretation, you can't put a sinus rhythm because the P wave is not coming from the SA node. So what you would put is atrioventricular or AV paced, don't forget, with complete capture. The next one here is kind of like the previous one. So we have pacer spikes all the way across. I have an atrial rate of 1, 2, 3, 4, 5, 6, 7. So an atrial rate of 70. A ventricular rate of 70. It's going to be regular. P waves are present with the pacer. PR interval, well, we just count 1, 2, 3, 4, 5, so it looks to be about 0.20 second. QRS complex starts here, that's about 3, 4, so 0.16 second. Interpretation, AV paced with complete capture. This one here is a little bit different. It looks like we have a ventricular paced rhythm right here. So we're going to look at the first part of the rhythm here, which looks to be a sinus rhythm. So we have a P wave and a P wave. So we have an atrial rate of, we'll say 300, 150, 175. So we'll say maybe an atrial rate of about 70 beats per minute, which goes to 0 beats per minute because the pacer basically takes over because the P wave stopped. The ventricle, though, the ventricular rate, 1, 2, 3, 4, 5, 6, you could say that it's 60 beats per minute. Regularity, this is going to be irregular. It can't be regular because the ventricular, or in this case, the atrial escape interval, expired. So we're going to say that it is irregular. P waves, present and married into absent. Why? Because the P wave probably stopped firing. It went into a sinus arrest. The PR interval, when present, it looks to be about 0.16 second when present. The QRS complexes, when they were good, when they were narrow, over here they look like they're narrow, so it's 0.108 second. Over here, when they're paced, though, they look to be 0.16 second with the pacer. How would you interpret this? Well, you'd have a sinus rhythm into ventricular paced with complete capture. Moving on to this one, we have what appears to be, I wonder if these are normal beats or PVCs. I'm betting those are PVCs because there's no P wave in front of them to indicate that those are normal, and they're wide and bizarre looking with the QRS and the T wave traveling in opposite directions. So I'm betting that those are PVCs. So do we have an atrial rate? We do not. How about a ventricular rate? Remember, you count the PVCs too. 1, 2, 3, 4, 5, 6, 7. 70 beats per minute. Regularity is going to be irregular. P waves are absent. PR interval is none. QRSs, they might be about the same width, it looks like. So we start here, there's 2 boxes, 1, 2, 3, there's 5. 1, 2, 3. So 0.20 second when paced, and 0.12 second at the PVCs. How would we interpret this? This is a ventricular paced with complete capture and unifocal PVCs. The next one here looks pretty simple, but there's some other things going on here. These little blue dots right here, These are showing where there are P waves. If you march these things out, you might be able to detect P waves. So let's pretend that each one of those blue dots is a P wave. So we're going to say the atrial rate is 1, 2, 3, 4, 5, 6, 7, 8. The ventricular rate is 1, 2, 3, 4, 5, 6, maybe 6.5. So we'll say 65. Regularity, now we're looking at the P waves, the QRSs, so we're going to say the regularity is regular. If you do the R to R interval, P waves, they are present, but what's the problem? Not married. Those P waves do not cause the QRSs. The PR interval is none because those P waves do not cause the QRSs. The QRS width will be 1, 2, 3, 4, so we'll say 0.16 second. The interpretation of this could go a couple ways. First of all, you could call it a third-degree heart block, but technically it's not a third degree because the ventricle isn't depolarizing at its intrinsic rate. The SA node looks to be depolarizing normally like it's supposed to. So what's probably happening here is there is a block somewhere going on that is not allowing the P wave to communicate with the ventricle. So the ventricle is taking over, the pacemaker is taking over the ventricular pacing. You could call it a third degree. I'm going to interpret this probably a little bit differently. I'm going to call this ventricular paced with complete capture and AV dissociation. So this one I got out of the book was very difficult, and you can't really tell what's going on here. It looks like a very wide rhythm. So is this an accelerated idioventricular rhythm? Is it a junctional with a bundle branch or some kind of an aberrancy of some kind? It's really difficult to tell. If you look at this right here and the patient is talking to you normally, then you should probably do a 12 lead. If we were to try to identify this or interpret this, it would be difficult. So let's say the patient is alert, awake, and talking normally. Atrial rate is unable to attain. What is our ventricular rate? 60 beats per minute. It's regular. P waves are absent. PR intervals are none. The ventricle, I don't know what is all this going on here. This might be a retrograde P wave. I can't tell. So I'm going to say this is 3, 4, so 0.16 second. But what is it? If the patient's talking to me, maybe it's a junctional rhythm with a bundle branch block? I don't know. So let's do a 12 lead and find out. After you look at some other leads, you come up with this lead. Here's V2, and it's the same patient. Now we have something to go on because we see these little pacer spikes. So let's try it again. So our atrial rate is unable to obtain because we can't see that. Ventricular rate, 1, 2, 3, 4, 5, 6, so it's still 60 beats per minute. Regularity is still going to be regular. P wave is still absent. PR interval is none. The ventricular width looks to be about the same, so we'll just say 0.20 second. Now that I see that this is a paced rhythm, I can more definitively identify this as a ventricular paced with complete capture. I hope you enjoyed this presentation on paced rhythms, and if you have any questions, please feel free to contact me. And as usual, practice. That's the best suggestion I can give you.